Hello, everyone, and welcome from wherever you are in the world to the second day of the Asia Pacific Stroke Conference held in Korea. I'm Dr. Ramani, a neurologist in Singapore. I'm the CME chair for the Asia Pacific Stroke Organization and the co chair of the International Scientific Committee of the APSC this year. Welcome. We have a very exciting conference this year, and today I'm welcoming you to the plenary session 2 on advances in acute stroke care system by two renowned speakers. The first lecture is on the late time window strategy given by Professor Jung Ho Rah. Professor Rah is a professor of neurology at the Inha University Medical College. He graduated from Seoul National University Medical College, has an exciting career through SNU, Catholic University Medical College, and is currently professor of Inha University Medical College. Professor Rah, please give us your lecture on late time window strategy. Thank you.
Hi everyone, I'm Jung Ho Rah, Inha University Hospital Neurology, Korea. Today in this session, I'll talk about the late time window strategy. First, we'll briefly review the current guideline of IVTPA and endovascular thrombectomy in late time window, and also we'll see recent efforts to expand the EVT eligibility, and then very late time window case, and artificial intelligence, posterior circulation stroke, and late window paradox. Before we go further, I just want to make clear the term. It's just my personal opinion, not official, but in most articles it is usually described as, when you say late for the IV TPA, it means for more than 4.5 hours. And for endovascular thrombectomy, the early window is until 6 hours, and late window 6 to 24 hours, and when it's over 24 hours, it is usually called very late. The current guideline of IVTPA for late window is based on a diffusion flare mismatch concept. It means the diffusion region is less than 1/3 of the MCA territory and there is no flare change, which is based on many trials like the MR Witness trial or the Wake Up trial, which is more confirmative and clearly showed the efficacy of alteplase for late window. So when we see a patient with unknown onset and the less known wear time is already past 4.5 hours, but still within 4.5 hours from the symptom recognition, using the diffusion flare mismatch, we can start IV TPA. And there are many similar articles using TNK TPA, so maybe in some day we can use both drugs for the IV thrombolysis in late time window. After the 5 pivotal trials in 2015, the endovascular thrombectomy within 6 hours is well established. Among them, the ESCAPE trial includes the patient within 12 hours. And the result of the 6 to 12 hours, the late window of ESCAPE trial, the efficacy was comparable with the early window patient. So it gave a clue for the endovascular thrombectomy even in late time window. And in 2018, 2 confirmative trials, the DAWN and the DIFFUSE trial, clearly proved efficacy of endovascular thrombectomy for the late time window from 6 to 24 hours. And there were many following editorials, and the guideline was also changed according to the result. So when you see a patient with large vessel occlusion in the anterior circulation, from 6 to 16 hours using the DAWN or DIFFUSE 3 eligibility criteria, and after then from 16 to 24 hours using the DAWN eligibility criteria, we can try the endovascular thrombectomy. The eligibility criteria of the studies was, in DAWN trial, they enrolled the patient from 6 to 24 hours, and they stratified the patient using age and also the NIHSS. So there were 3 groups, and they assessed the INFRA-core using the CT or MR, and they used the concept of the core clinical mismatch. And in diffuse 3 trial, they enrolled the patient until 16 hours, and in fact, core volume should be less than 17 milliliters, and they used the target mismatch pattern. So the core volume and the ischemic tissue volume using the perfusion image, the ratio should be more than 1.8. And in both trials, the RAPID software was used for image analysis. And one of the problems of current guideline is not all the hospitals are equipped with the RAPID software. Sometimes they use another software for the analysis, and sometimes they use the collateral status by the CT or MR angiography for patient selection. So it can be regarded the current guideline criteria of the endovascular thrombectomy in late time window is very narrow. So we'll see from now that there are many trends to expand the endovascular thrombectomy eligibility for the late time window. This study from Lausanne, Swiss also tried to expand the endovascular thrombectomy eligibility criteria of late time window. They consecutively enrolled the late time window patients for last 15 years. And more than 4,600 patients were screened, and among them, almost 1,000 patients were late time window, and 221 patients had large vessel occlusions, so they were subject to endovascular thrombectomy for late time window, and they applied the Dunn criteria and diffuse 3 criteria and their own criteria, which used the lower NIH stroke scale and lower aspect score, so which means their criteria was more liberal. And the result was, when they used the Dunn criteria, 23 patients were subject to endovascular thrombectomy, and diffuse 3 criteria, it is 47, and when they used the more liberal criteria, more than 100 patients were subject to endovascular thrombectomy in late time window, and overall, about 6% were eligible to EVT using Dunn or diffuse, and about 11% was subject to EVT using more liberal criteria. So it is more, almost double the size. Of course, this study does not compare the result of the thrombectomy in these patients. So what would happen if we really do the thrombectomy in more liberal criteria patient? This study gives some clue to that question. They participated in both the Dunn and the diffuse 3 trial, but about a quarter of patients did not meet the Dunn or diffuse 3 criteria, and they enrolled the 45 patients for the Dunn, 47 for the diffuse 3, and 142 patients were non-Dunn and non-diffuse 3, but among them 37 patients received the endovascular thrombectomy because the investigators felt that it is necessary in this late time window. And the result was, the modified ranking score of the non-Dunn, non-diffuse endovascular thrombectomy group was not different to the diffuse 3 or Dunn endovascular thrombectomy group. So from this result, we can say that even though some patients cannot meet the diffuse 3 or Dunn criteria, the endovascular thrombectomy can be helpful. And there are other studies to expand the endovascular thrombectomy eligibility in late time window using non-diffuse 3 or non-Dunn criteria. And this Korean study tried to show that not only the perfusion-based triage like Dunn or diffuse 3, but also the collateral status estimation-based selection of endovascular thrombectomy can be helpful. They screened 132 patients of large vessel occlusion in late time window, and 93 patients had all those imaging data set. And 76 patients meet the criteria of DON or diffuse 3 using perfusion imaging based selection, and 69 patients had the collateral status assessment using CT or MR angiography and selective to endovascular thrombectomy. And among them, almost 70% of patients were received endovascular thrombectomy in each group, and the result was the collateral status assessment group was actually better compared to the perfusion-based selection, but the result was not statistically significantly different. But anyway, this study shows the possibility of collateral status assessment-based triage of the endovascular thrombectomy in late time window. This is another study which compared the CT angiography and CT perfusion in late time window, and it was most difficult to meet the DON eligibility criteria, and then next the diffuse 3, and the collateral status assessment by CT angiography was the easiest way to meet the criteria. And the result of the endovascular thrombectomy between each criteria was not quite different. So this study also gives some possibility of collateral status assessment triage of the endovascular thrombectomy in late time window. We remember that in the beginning of IVTPA, there were so many contraindications, almost 30. So we could not give IVTPA to diabetes and previous stroke history patients. It was quite hard to understand. Those contraindications were just exclusion criteria of the trials, and there are no scientific evidence that giving IVTPA is more harmful than beneficial in those patients. So after many studies, many exclusion criteria is now eliminated, and also other exclusion criteria is considered relative. So now we can give IVTPA to rapidly improving symptom or seizure at onset. And I think just like the history of the inclusion and exclusion criteria of the IVTPA, the endovascular thrombectomy criteria for the late time window can evolve to more liberal and practical criteria. At present, by the current guideline, we have to follow the diffuse 3 or DON criteria using rapid software, but in the future, maybe we can use the collateral status assessment criteria for the endovascular thrombectomy in late time window, just like in the early window. But for the purpose, I think more definitive trial is necessary. Now we'll move to the very late time window for more than 24 hours from the onset. This is a case I recently experienced. A young lady, 33 years old. She felt some speech disturbance yesterday, so visited nearby hospital, and the MRI was like this. There is some diffusion signal change in left posterior temporal parietal area, and she was transferred to our hospital. After arrival to our emergency room, she developed right side weakness, and we followed the MRI, and there are newly developed diffusion signal change in left periventricular subcortical area, and the MRA revealed the left M1 proximal occlusion, and there are large perfusion delay in whole MCA territory. But she is already past 30 hours from her initial symptom onset of speech disturbance. So what are you gonna do with this patient? If we have to say, oh, you are too late, already past 24 hours, so we have nothing to do? Of course, we decided endovascular thrombectomy in this patient, though it is already past 30 hours. An initial angiogram showed tight amon stenosis and almost near occlusion, and there are faint feeling of the MCA. And after solitary thrombectomy, we could achieve the TK2B recanalization, but there are mild residual stenosis was noticed. But anyway, her symptom, speech disturbance and right side weakness, is completely improved after the recanalization, and she could go back to her normal life. Recently, our Korean colleagues published good articles about the very late time window thrombectomy. And they registered more than 150 patients of very late time window from 16 hours to almost 10 days, and analyzed the result. The outcome of endovascular thrombectomy in this very late time window patient was much better compared to the best medical treatment. So we can say, even though in the very late time window of more than 24 hours, in some selected patients, endovascular thrombectomy can be helpful. And the effectiveness of the endovascular thrombectomy is actually getting higher from the onset to the intervention time. So it is compatible with the so-called late window paradox we'll discuss later. Now I briefly mention about the artificial intelligence for the endovascular thrombectomy selection, and then move to the posterior circulation stroke. Artificial intelligence is getting more and more involved in our life, and now we can see the brain imaging of the patient through the mobile phone and see the result of the analysis and make decision. There are already many studies have been done using AI for the stroke imaging, and there are already systemic review about that. Currently, 3 AI software, Rapid, Brainomics, VisuAI, is competing in the field of neuroimaging analysis for stroke. I think in the near future, these AI software will greatly help and also influence our decision making of individual patient and also our stroke organization system. Until now, most evidence of endovascular thrombectomy is confined to anterior circulation, but we still see many patients of basilar occlusion and do the endovascular thrombectomy. So we need to establish sound evidence of thrombectomy for the posterior circulation stroke. In this REVASC registry, they compared the endovascular thrombectomy result between anterior and posterior circulation stroke, and they found that in the posterior circulation stroke, thrombectomy patients are younger and more time delay and a low risk of symptomatic hemorrhage, and most importantly, the odds of favorable outcome is quite good, even in the late time window and early time window compared to the anterior circulation. And this Batman study estimated the collateral status assessment for the selection of the posterior circulation stroke. They developed the scoring system of the posterior circulation. So each vessel of the vertebral basilar artery is allocated to some point. So if the Batman score is high, it means that the collateral status is good. And when the Batman score is high, the outcome within 6 hours and after 6 hours endovascular thrombectomy is not very different. But when the Batman score is not good, the outcome within 6 hours and after 6 hours is very different. It means that the posterior circulation thrombectomy is quite dependent on the collateral status, just like the case of the anterior circulation. In the BEST trial, we had a chance to establish sound evidence for the endovascular thrombectomy of basilar arterial occlusion. But while the study was going on, EVT for anterior circulation was established, and many investigators thought there is no more clinical equipoise for the basilar arterial occlusion endovascular thrombectomy. So in this study, 131 patients were enrolled and allocation was half and half, but among the 65 patients to control group, 14 patients did not agree to receive best medical treatment, and they were switched to the intervention group. So these 14 patients result was included in the intervention arm in the intention to treat analysis and per protocol analysis. So the result was almost neutral. But when we analyzed the result as treated, then the outcome of intervention was quite better than the best medical treatment. So I think this result was tragic because we lost the chance to have the very good, strong evidence of the basilar arterial occlusion embolectomy. And I think further clinical trial is very difficult to run because many investigators think that it is not ethical to give just best medical treatment for the basilar arterial occlusion. Finally, I discussed about the late window paradox and the challenging concept of ischemic penumbra. As soon as the Dunn and Diffuse 3 trial was published, it was noticed that the effect size of the thrombectomy was even better in late window compared to the early window because the outcome of control group was better in the early window, and that makes the difference in effect size and called the late window paradox. They explain the reason of late window paradox as follows. In some patients, the ischemic penumbra evolves to infarct very rapidly, but in other patients, the evolution is very slow. And in the early window trials, they have more chance to include the rapid growth patient compared to the late window trials. They have more chance to include the slow progressor patient. So that could make the difference in effect size of the endovascular thrombectomy. But that reason alone cannot 100% explain the late window paradox. And we still have more that we do not know than we understand. So these days, many investigators agree that we cannot precisely determine whether an ischemic tissue will finally evolve to infarct core or a viable tissue, and moreover, the resulting infarct volume, it does not always correlate with the clinical outcome. So, compared to the term ischemic penumbra, they suggest a new term, the severely ischemic tissue of uncertain viability. There are many examples of such as uncertainty. In these patients, both have M1 occlusion at the onset, but in the left image, the whole MCA territory has a homogeneous infarct, but in right side image, only the gray matter shows the diffusion change, and the white matter is relatively safe. And we cannot precisely know whether this M1 occlusion will evolve to the left side image or right side image. If we compare the infarct volume with the clinical outcome, the MRS score usually correlates well with the infarct volume, but there are many outliers for that. And in this right side figure, strangely enough, even if the infarct size is the same, if the infarct volume is not very large, then the clinical outcome is different. It means that the clinical outcome of the recanalized patient is better than the non-recanalized patient, even though the final infarct volume is the same. It means that all the infarct is not the same. It depends on the status of the recanalization. So at present, we do not know the exact mechanism of these discrepancies. We have reviewed the current guideline of IV thrombolysis and endovascular thrombectomy in late time window, and also we have seen recent efforts to expand the EVT eligibility. EVT can be helpful even in very late time window over 24 hours in some selected patients, and artificial intelligence is evolving and competing, especially in the field of stroke imaging. We still need sound evidence for the posterior circulation thrombectomy, but many investigators think there is no more equipoise in that, so it is very hard to run another trial. Finally, we cannot precisely determine the fate of ischemic tissue, so there are still many things we have to investigate. I hope you enjoyed this session, and as a Congress Chair, thank you all for attending the Asian Pacific Stroke Conference 2020.
Okay. Thank you very much, Professor Ra, for a very exciting lecture. Really enjoyed that. We will take questions after the next speaker. Professor Libiskin will be coming online now to give a lecture on new decision-making platform for acute endovascular therapy.